Good evening, everyone. Welcome. I'm Dr. Sayeda Rukshida. I have the honor of being the General Secretary of Indian Association of Biological Psychiatry. And for the last 2 years, we have an ongoing series every first Friday of every month. It's a curated series. It's an open access series. We even upload it on our YouTube channel later. This is all in service of biological psychiatry and clinical practices for everybody, whether they're based in urban, rural, standalone practices or clinical setups. With this, we hope that more and more of us who may have become a little complacent can upgrade our skills, and who are eager to learn and a forever student, and we encourage them to continue doing that. Welcome. We try and curate topics every month that we think that might be of interest, especially around if there is an awareness month going on and during that time. And we have a tradition of having one of our EC members give the welcoming remarks and introduction of the chairs. So it's a great pleasure for me to invite the editor of IABP, Dr. Aleem Siddiqui, who's a senior psychiatrist from Lucknow. All of us know him and love him. He's also the treasurer of Indian Psychiatric Society, and of course, a huge a cricket player and a badminton player and winning medals off the field and on the psychiatry field as well. So over to you, Dr. Aleem, and please share your remarks.
Thank you, Dr. Rukshida. It was too kind from you, skipping out the errors and focusing on the positives. Thank you so much. Thank you so much. A very important topic and a very one of my personal favorite speaker, Ashwin boss, is there. So we'll listen to him in just a short while. As an editor, as the editor of IABP, let me bring you some good news. We have now been able to complete the first issue of the journal, the Archives of Biological Psychiatry, and we have launched it online right now. So our first issue is live as we are on this webinar. So please visit the site and provide your feedback. And coming back to the webinar of today, I'll introduce persons. Dr. Ghosh, very dear personal friend. He is Associate Professor of Psychiatry at Silchar Medical College. He is Treasurer of this society, IABP, Editor of IJPP, and EC Member, Zonal Representative of IPS. He has more than 50 publications and citations. Welcome, Prasenjit. And my pleasure to welcome Dr. Sarika Sukar. She is Deputy Superintendent and Associate Professor and Head of Unit in the Department of Psychiatry in the De-Addiction Center, Government of Maharashtra, Nodal Officer in Drug Treatment Clinic, Gokul Das Tejpal Hospital, Grant Government Medical College, and Sir JJ Group of Hospitals, Mumbai. She has a lot of academic credentials and very good organizing capacity. She has organized trainings for healthcare workers, moderated and organized webinars. She was part of the team to prepare protocol for healthcare workers on mental health issues during the COVID times. She is winner of LP Shah 2012 and AV Shah Best Paper Award in 2004. Various national and international publications she has to her study. So it is our honor to welcome you, Dr. Sarika, and and over to Dr. Ruksheda for the proceedings.
Thank you, Dr. Aleem, for those kind remarks and kind introduction. And now that you have introduced the chairs, I'm going to hand over the proceedings to the chairs. I think Dr. Sarika is going to introduce the topic and Dr. Ghosh is going to introduce the speaker. So over to you, Dr. Sarika.
Yeah, hi one and all, and to all the dignitaries, senior psychiatrists, friends, colleagues who are attending it. The topic is really a brainstorming thing, as in, are we really treating it, or we are only substituting when a patient of opioid dependence comes to us? So what are we doing? Sometimes, as you see, I also run a DTC. So sometimes you are really puzzled. What am I doing? Am I really treating the patient, or I'm just giving a substitute so that the patient continues for a while. Why can't I just get that patient out of this drug? Why his body is not free of the drug? And it is the basic question, to be or not to be, treatment or substitution maybe. And looking forward, from Dr. Ashwin Mohan, who himself is a good speaker, and over to Dr. Prasanjit Ghosh for introducing Dr. Ashwin Mohan. Thank you.
Thank you, Madam Sarika, Madam. Dr. Ashwin Mohan, our tonight's speaker, is a senior psychiatrist based at Chandigarh. He did his postgraduate in psychiatry from PGI Chandigarh in 2000. Then he did his PG DMLE from National Law School, Bangalore in 2016. His areas of interest are mainly substance abuse disorder, mental health law and policy, mental health advocacy, and forensic psychiatry. Apart from that academic part, he is also a voracious reader and a very good cook, as informed by our honorary secretary, madam. So we hope to taste someday at Chandigarh at his residence, his culinary skills. Jokes apart, as rightly told by my co-chair, I am also working as a nodal officer for last 4.5 years of a OST center at Silchar Medical College. And sometimes we do feel actually helpless. And what we are doing is actually nothing but harm reduction, or we are treating the patient. The question comes to our mind. So these few words, I would like to hand over to proceedings to our speaker tonight, Dr. Ashwin Mohan. Thank you.
Thank you, Ruksheda, and the other office bearers of IABP for inviting me for today's today's webinar. And also I see that my chairpersons are equally experienced in dealing with addiction and patients of addiction, and have rightly pointed out the dilemma that they feel, or in fact, we all feel many times while treating this very difficult population of patients. Now, there are a couple of reasons why I have chosen this topic, maybe more than a couple of reasons, but the main reason is that this has been a raging debate in the last couple of weeks or so because of an unfortunate incident with a colleague of ours, and this has been debated in WhatsApp and other social media groups about whether this is a treatment or this is just substitution, and people are just dispensing the medication to patients of opioid dependence, not actually treating them. The second reason for choosing this topic is, of course, we all of us know that June 26th, this month itself, is the International Day Against Drug Abuse. So I thought it was an apt moment to choose this kind of a topic to highlight this week, this day, and which is celebrated for the last many years. Now, apart from this, you see, I'll begin my talk. I'm just sharing my slide. Okay, slides are visible. Am I audible?
Yes, yes.
Yeah, thank you so much. So the topic today is opioid dependence. It's actually opioid agonist treatment, whether it's substitution or treatment itself. So my topic today includes, actually, you see, I thought that this is a webinar on biological psychiatry. So my topic actually includes the basic neuroscience of opioid dependence, a brief about that, the rationale for using OST, implications for the use of OST. It excludes any guidelines, any methods of clinical issues which are dealing with OST. It excludes detailed description of buprenorphine and methadone and the process and how they use it in treatment, and actually avoiding any legal, regulatory, ethical, and procedural issues about OST. So I thought I'll stick to this mandate given to me, and that is biological psychiatry, and try to find out, is there actually neuroscientific basis of using buprenorphine or such agonists for the treatment of opioid dependence, or are we just substituting it substituting one drug from another. So we all know the benefits of OST, and just to recap, what are the benefits? See, OST is a scientific, effective and efficacious and safe form of treatment, and there is no doubt about this. Hundreds and hundreds of papers have been produced to show that it's a very scientific and robust kind of a treatment. It manages withdrawal symptoms and cravings, stabilizes mood, improves access to healthcare, reduces use of illegal opioids and other substances, reduces injecting, harm reduction. A person is not actually going to chase a high the whole day, like looking for his fix. It's also a great analgesic. A patient feels more energetic, has better sleep and health. There is improved family relations and societal relations. There is overall increase in quality of life and reduction in crime. These have been proved umpteen number of times, and I think really there is no debate on the benefits of what OST can provide to a patient of opioid dependence. But let me start with a story. This is actually a true story, and this is to highlight what actually happens probably in opioid dependence. See, in 1944, at the height of World War II, there were 36 volunteers who were responded to a government brochure of will you starve that others be better fed. There was a humanitarian crisis. There was a humanitarian crisis in terms of food, resources, and people who never, they had to actually allocate resources depending on need, and to find out if people, if they reduce their amount of food and they, so that it could be distributed to other people who might need them more, or soldiers or the war front. So this kind of an experiment took place in Minnesota in 1944, and these young men were brought into the University of Minnesota football stadium, and over the next 6 months, they were made to starve, and they were made to lose 25% of their normal body weight. They showed a slowing of most of the physiological processes that they expected. And the important part was that the psychological sequelae were very profound. It was not just that they showed some differences in basal metabolism and hypertension, sugar levels, but the psychological sequelae were very profound. They became obsessed with food, lost interest in sex, social interactions. They became irritable, depressed, impulsive. In fact, one participant actually amputated 3 of his fingers with an axe. But what happened next? When participants were actually gradually fed after the experiment was over and then discharged, it was assumed that everything will become normal and they will go back to their normal life. But for many of them, the impact persisted well beyond. They remained obsessed with food, experienced distress with specific food cues, and continued to maintain compulsive food-seeking behaviors. Even years after that starvation experiment was over, with unrestricted food, access to food, a number of them did not really report any relief from feelings of hunger. The belief was that following removal of that stressor, the systems would come to the baseline, but for some people, it never did. Sounds familiar? This is what happens to a patient of opioid dependence. But perhaps the most complex and perplexing and frustrating aspect which is seen in opioid dependence is what I explained to you in this previous experiment, was that there is a dramatic shift seen in the individual's behavior. This brings us to the concept of incentive salience, that is how the brain attributes value or importance to subjects in the environment. In opioid dependence, a patient actually prefers and gives more importance to the substance, that is the opioid, rather than to other cues in the environment, and therefore preferentially tends to use cues in the internal and external environment and to seek that particular opioid. Neurobiologically, the drug is perceived as holding greater value than naturally occurring rewards. This is what exactly happens, and this is what we see clinically as the importance for the drug. So when patients and doctors keep telling, oh, तुम क्यों drug ले रहे हो? इसको छोड़ दो, तुम्हारे पास सब कुछ है, तुम्हारे पास पैसा है, तुम्हारे घर में बीवी बच्चे हैं, and all that kind of commonsensical stuff that we keep giving our patients, hoping that somewhere somehow they will start being मतलब समझ जाएंगे चीजें क्या हो रही हैं, क्या नहीं हो रही है. Unfortunately, it is not as simple as that. And this is where most of our clinicians make a big mistake. They do not understand this concept of incentive salience and how much importance a particular drug holds for that patient once he becomes dependent. This is important, once he becomes dependent. not necessarily in the earlier stages. What clinicians have also noted, apart from that incentive salience part, that there is persistent emotional distress. You find most patients who come who have who are either even addicted or taking drugs, or who have left drugs. There is this persistent emotional distress or dysphoria which keeps happening with them. They never seem to be happy. They always seems to be distressed. They always seem to be dysphoric, alexithymic. I mean, they show lack of pleasure. They have some depressive symptoms, and there is a dysregulation of 3 sets of systems here, which you must understand. Those responsible for mood, those responsible for pain regulation, and those responsible for reward seeking. So these 3 systems tend to interact with each other and cause this continuous persistent emotional distress. So I am not going to go into too much of detail of these systems because we will veer from our topic, but it's important to understand that the mood regulation is affected, pain dysregulation occurs. These patients become hyperalgesic. Their pain threshold is reduced. For small things, they would start experiencing pain, which normally people would disregard. But for them, it becomes very, very important and a cue to seek relief. Together, these changes interfere with the patient's ability to derive pleasure from everyday life while simultaneously promoting distress. And this phenomenon is called hyperkataphia. Kataphia in Greek means dejection or sadness. So there is this hyperkataphia state which is induced when a person is actually continuing to take drugs for a longer period of time and is dependent, whether he's abstinent or not. Like the Minnesota starvation experiment that I alluded to earlier, it leaves people endlessly hungry, and chronic opioid use may render some people insatiable for positive effect. So they will keep seeking that positive effect, whatever happens. The changes in the set points of the brain for pain, reward, and mood regulation, together with the net effect of increasing opioid seeking behavior, has an overriding inhibitory control over their actual cognitive faculties of executive cognitive faculties, of whether they can actually control their use or not. But the set points of the brain in these circuits change, which makes it very, very difficult for them to execute control over their behavior. So this is a typical life cycle of what happens when drug dependence. There is an initial use of drug, and which causes withdrawal, initial euphoria and withdrawal. There will be symptoms of withdrawal after a person stops. There will be stressors. There will be cues which is related to the usage of the drug, and it will lead to relapse. And the relapse part, which we see in the end of this thing, starts occurring very frequently. So initially what happens is that this cycle of euphoria and withdrawal may be a little slower, but as a person becomes dependent, this becomes much more closer and much more faster, rendering a patient much more vulnerable to relapse. So this is what happens is, again, a schematic diagram, just to highlight what I said earlier. Early, there are genetic factors and life stressors which may prompt an early use, leading to regular use, compulsive use, and finally addiction. And of course, there might be a period of protracted abstinence, which may lead to relapse later on. So 3 key components are there with 3 circles that you see on the right. That is pain catastrophizing, because there is hyperalgesia, impaired decision making, which I said, which is incentive salience, and hyperkataphia, that is a pervasive, persistent, distressed emotional state. These 3 combine together to lead to relapse. Of course, during the time between early use and this particular state of relapse, there are multiple factors which may intervene. So what happens in opioid addiction in the long term? The opioid addiction is a chronic disorder with frequent relapses. We all know that. So what I have highlighted earlier is the fact that there are multiple factors which are important to understand. Factors in our neural circuits which lead to relapse. These 3 circuits of mood, pain, and hyperkataphia are involved together and intertwined together, leading to a
persistent state of addiction and relapse. A longer-term retention is associated with greater likelihood of abstinence. Over the long term, the mortality rate of opioid addicts is almost 6 to 20 times greater than that of the general population, overdose being the main reason. And amongst those who remain alive, the prevalence of stable abstinence is less than 30% after 10 to 30 years of observation. So you see, there is a great challenge to keep these patients alive, one, abstinent, two, and returning to their functional life and rehabilitation, so-called, whatever that means. So these are the greatest challenges that we feel that we encounter while treating a patient of addiction. Of course, histories of adverse life experiences and comorbid mental disorders are associated with persistence of opioid use. Family social support are important in recovery. And maintaining opioid abstinence for at least 5 years substantially increases the likelihood of future stable abstinence. Again, what does this mean? Retaining the patient for treatment over a longer period results in a greater likelihood that he will be abstinent in the future, or even if he is retained in treatment. So this is again just a schematic diagram which I've talked about earlier, having 3 phases: the binge intoxication phase, the withdrawal effect phase. The binge intoxication phase is usually associated with the reward cycle. The withdrawal negative affect stage, which leads to hypercataphia, and preoccupation and craving, preoccupation and anticipation, which is actually the craving part. These 3 circuits interact with each other and lead to this vicious cycle of relapse. So what drives this opioid addiction? What happens actually? So I've actually talked about the larger systems and circuits which are involved, but what happens at a micro level? So as you see, I've focused in this talk, I focused mainly on the neuroscience of opioid systems and opioid treatments rather than going on to the other aspects of treatment, about more clinical aspects. So there are 3 opioid receptors called mu, kappa, and delta opioid receptors, having different distribution and different effects. They are stimulated by endogenous opioid peptides, which are there in the body, forming which include beta endorphin, enkephalins, and dynorphins. They're distributed throughout the nervous system, and opioid peptides and receptors reduce responses to painful stimuli and stress. So they modulate painful stimuli and stress and influence reward processing and mood, which I described earlier. The activity of the endogenous opioid system is extremely broad. So addiction or leading to addiction or pain relief is just one part of it. It's actually extensively distributed in the body, and they cover many other aspects of physiology and behavior, which are very important for survival, but they are less related to addiction. So we must not think that opioid means addiction and nothing else. They're actually very important for many other systems. So dysregulation of opioid neurotransmission is the main driver for drug abuse. So we know that the receptors and their dysregulation is important. The addiction thus becomes a complex relapsing disorder in which drugs of abuse hijack, overstimulate, and compromise the reward processing in associated networks. So this is the final outcome of what happens when there's a dysregulation in this opioid transmission system. So it becomes a system which is hijacked, overstimulated, and compromised in the reward processing system and associated networks such as regulation of mood and stress. All 3 opioid receptors are involved in this process, although they have different contributions. So again, we must please remember this, because I will come to this later and see how the treatments actually affect these receptors later on. So this is again a schematic diagram about what the mu opioid receptors, the delta opioid receptors, and the kappa opioid receptors interact with each other. This is the diagram on the left side, and then eventually lead to this vicious cycle of relapse. So they have different effects. The mu receptors are usually associated with pleasure and reward, while a dysfunction in the mu, delta, and kappa receptors can lead to lower self-control and higher incentive salience. And similarly, what is seen with the kappa opioid receptors can lead to other effects. So these receptors actually interact with each other, though their distribution and effects are different, and eventually combine together to lead to addiction. So what does this mean? If opioid receptors are the driving force of addiction in these different circuits that I have mentioned, what does it actually imply? It implies that in principle, opioid receptors, targeting them should be the ideal ways to treat drug abuse, isn't it? So if we do not actually deal with anything that these receptors do, will treatment become successful? The answer is actually no. This is where again our practitioners falter to understand that when we do treatment, we are actually targeting these receptors by using agonist treatment. So when we try to use some other kinds of treatment and some other kind of painkillers, for example, fluperitin or pregabalin or ketorolac or simple NSAIDs, we are not targeting these receptors. So they will never achieve that kind of relief that a patient of opioid dependence actually desires from you. And there is where that these practitioners make a huge mistake. So the mu receptor blockade, it could reduce reward and the motivation to seek drugs and compulsive behavior. So if we target the mu receptors, we can achieve this. The kappa blockade should limit dysphoric states. Dysphoric states are most important in relapse, associated with stress and drug withdrawal. To prevent stress-induced relapse, blocking KORs may actually also reduce compulsivity. So the kappa opioid receptor blockade leads to certain other effects as compared to the mu opioid receptor. Finally, the delta opioid receptor activation should reduce anxiety, limit compulsivity, but may also facilitate drug context learning. So 3 receptors, targeting them can actually achieve some of the desired effects that we expect from a treatment to an opioid dependent patient. But today, amazingly, there are very few opioid drugs available and used in clinical practice. This is partly because of our inherent bias and the stigma attached to these molecules. There are hundreds of opioids which are available, both licit and illicit in the market. But firstly, because of regulatory issues, there is very little research, and partly because of our own inherent bias. In our means does not mean practitioners, but also authorities, administrators, the enforcement agencies, everybody. So they view any opioid as a drug of abuse and do not have any therapeutic use. So we use buprenorphine very frequently. What is so special about buprenorphine? Why do we use buprenorphine for treatment of opioid? Why not any other opioid? There are so many other opioids that we can actually use. So buprenorphine is actually a partial mu receptor agonist. And the properties that result from its unique structure and receptor binding and downstream receptor signaling events, which I'm not going to go to. The therapeutic effects are mediated through interactions with the different opioid receptors, mu, delta, kappa, and opioid receptor 1, distributed throughout tissues. So importantly, understand that buprenorphine targets all the 3 receptors which are described earlier, which are involved in addiction. It has high binding affinity for mu and is also an antagonist with lower binding affinity for delta and kappa opioid receptors. So today I'm actually going to deal with buprenorphine because in India we have buprenorphine, which is much more commonly used as compared to methadone. But methadone has some similar properties. But for today's talk, I'm going to restrict it to buprenorphine, otherwise it might become too long. So what happens? So buprenorphine has biphasic distribution. When you look at continued use and continued increase in use of buprenorphine, there is a ceiling effect that you see, that the graph tapers to a particular level. So partial agonists of the mu receptor bind to the receptors, but have a ceiling effect to the level of agonist activity. as compared to something like methadone, which is a pure agonist. The receptor occupancy keeps increasing. This is the second line that you see. I'm not sure whether you can see the arrow or not, which I'm pointing out, but this line keeps going up and up. So as the dose increases, the receptor occupancy keeps increasing. While for buprenorphine, it plateaus down. So this is this kind of response that we see when the increase in dose occurs. Even if the dose is very high of buprenorphine, the opioid effect is limited, and the risk of opioid overdose thus becomes minimal, because after a point it stops occupying more receptors. I hope I'm being very clear here. Now, buprenorphine has what is called a strong affinity for mu receptors. So what is affinity? Affinity is the strength with which the substance binds to a particular receptor. And second important property is dissociation. That is how easily it uncouples from the receptor. So when it is already bound. So the affinity and dissociation are the two properties of buprenorphine, which makes it somewhat ideal to be used as a treatment method. So it has very strong affinity for the mu receptors, so much so that it actually displaces any full agonist. Now, this is a very important fact because it can precipitate opioid withdrawal. So if a person is already on opioids and using opioids and you give buprenorphine, because of its strong affinity for the mu receptor, it can actually precipitate opioid withdrawal. And this is one of the major caveats which are given to patients, or which is practitioners tells the patient that he has to be opioid free, or when the withdrawal starts, the buprenorphine should be started. Otherwise, there is a strong chance of precipitated opioid withdrawal. Second, it dissociates very slowly from the mu receptor, and once bound stays tightly attached, so tightly that other opioid agonists given after buprenorphine has attached cannot displace it. Again, very important. So the chances of other opioids, if a person is already on buprenorphine, a person takes opioids, the chances of overdose are much lower because the other opioids are not able to displace buprenorphine, and therefore the other opioids cannot exert their full agonist effect on those receptors and thus cause other side effects. So these two properties, please remember, the strong affinity for the mu receptor and the dissociation, slow dissociation from the mu receptor is unique for buprenorphine and therefore are important facets of treatment. Important to understand that partial agonism is there to the receptor activity. It does not mean that there is partial analgesic activity. Again, this is a very common mistake that practitioners seem to make, that they read that a particular molecule is a partial agonist, but they feel that because it is a partial agonist, it has less use in certain things like, say, analgesia, as compared to full agonists such as morphine or methadone or codeine. But please understand that it has potent analgesic activity and efficacy. So buprenorphine is actually almost 25 to 115 times more potent than morphine and should not be considered less potent. So even lower doses of buprenorphine can produce good analgesic activity. Do not please dispel this myth that you need a full agonist for good analgesic effect. And good analgesic effect is essential for treating a patient of opioid dependence. So just a summary. I don't have too many more slides, but just a summary of what buprenorphine does. It's a partial agonist at mu receptor. Therefore, it has good analgesia, ceiling on respiratory depression and euphoria. Please focus on the left side of the slide, which have in the points in blue. It has limited impact on GI motility. As we know, opioids can cause severe constipation. There is limited physical dependence and abuse potential and withdrawal symptoms, reduce immunosuppression, reduce in suicidal thoughts, anxiety, and depression. Again, very, very important. We know, right, that buprenorphine is now being used for resistant treatment depression in many, many cases, and even helping in reducing suicidal thoughts. So this actually occurs because of this partial agonism at the mu receptor. It's a Antagonist at delta opioid receptors. So again, it has anti-opioid effects, limited respiratory depression. It is an antagonist at kappa opioid receptors. Coming to the third slide, which is in slight yellow. It reduces depression, dysphoria, suicidal tendencies, anxiety, limited potential for addiction and tolerance, and reduced immunosuppression. And of course, it has some other effects for the opioid receptor, opioid receptor 1, which mainly occurs at spinal sites. So it helps in other analgesic effects, such as after surgery, if a person requires treatment with buprenorphine, it is extremely effective. So you see this slide actually summarizes what the effects of buprenorphine are on different receptors, knowing well enough that if we go back, the opioid receptors drive this addictive process, and these opioid receptors are present in those three circuits, which I mentioned earlier: regulating mood and reward and pain. And in those circuits, there is a dysfunction in those circuits, which leads to what we cumulatively call as addiction. So you can understand what is the neuroscientific rationale of using buprenorphine. It is why this particular molecule and why not certain other opioids. I will come to some of those aspects again later. So just to summarize, and so that this is embedded in some of our participants' mind, the interaction of buprenorphine with opioid receptors is characterized by low efficacy or partial agonism, high affinity, high potency, and slow dissociation. These four factors, in summary, are important for using it as a therapeutic agent for treatment of opioid dependence. So what actually happens? What are the effects of medication-assisted treatment or opioid agonist treatment? So compared with patients who are receiving medication-assisted treatment, untreated participants have had a greater risk of all-cause mortality and overdose mortality. No doubt about that. If you leave a patient untreated, you do detoxification and leave him just like that, he has a greater chance of mortality, mainly due to overdose. Discharged patients from hospitals had higher risk of all-cause death and overdose death. Retention with MAT for over 1 year was associated with lower mortality rate than with retention less than 1 year. Please understand, again, longer term retention in treatment is key for patients to achieve one, survival, two, reintegration into their normal life. So when we have this kind of a bias of कि भाई 3 महीने हो गए, बंद कर दो दवाई, अब तो सब ठीक चल रहा है, तुम जरूरत से ज्यादा दवाई ले रहे हो, तुम लंबे क्यों खींच रहे हो? In family members start putting pressure on the treating doctor and the patient कि बहुत देर होगी दवाई लेते हुए, कब तक चलते रहोगे दवाई के साथ, अब तो टाइम आएगा आ गया बंद करने का. Please understand, this is the rationale behind it. Retention over greater than 1 year would mean lower mortality rate than retention less than 1 year. There is improved coverage and adherence to medication-assisted treatment and post-treatment follow-up are crucial to reduce mortality. Here, the slide is focusing on mortality because we see, I've already said that the chances of mortality are 5 to 20 times greater in these population of patients rather than the general population. So the 6-year retention rate in a particular study was 76% and average mortality was just 1%. During follow-up, 9.4% of patients became abstinent and 1.9% patients were referred for drug-free addiction treatment. Concomitant drug use decreased and somatic health status and social parameters improved. So this study, a 6-year outcome study in opioid maintenance treatment in heroin-dependent patients, shows the benefit of using treatment over a longer period of time. And similar is this, again, it shows that the emergency usage in hospitals or health facilities is much lower when you treat patients over a longer period of time. In this case, in this particular study, it was about 15 months. So what is the optimal dose of buprenorphine? This is again a dilemma that I have come across. Lots of our patients, lots of our clinicians face, who are even treating patients in drug addiction centers. So again, please focus on this and a couple of other slides, because this is very, very important. Effective maintenance dose of buprenorphine in reduced illicit use and improved retention may be achieved with doses in the range of 8 to 24 milligrams a day. So you require higher doses. Doses of 4 milligrams or less will not be as effective in retaining patients in reducing heroin dose. So we see this very commonly. Patients are given 2 to 4 mg and say, "ये तो बहुत ज़्यादा dose हो गई है, इससे ज़्यादा नहीं ले सकते." Plus, please understand that the scientific rationale of usage of 4 milligrams or less is very, very poor. It will not be effective in retaining those patients for heroin use. And when he starts using extra medication, you will feel that he's abusing the medication, because in your mind, you feel 4 mg is high. So what does the patient do? Does he go for relief? You see, please understand this very, very importantly. The brain does not care if it's 2 mg, 4 mg, 8 mg, 16 mg. The brain gives a damn. The brain is seeking relief. Your job is to provide relief. If you are not going to provide relief, that brain is a stressed brain, neurobiologically stressed brain is going to seek relief somewhere else. Now you have to decide, are you a facilitator of treatment, or are, because of your own biases and stigma that related to the medication or such patients too, you are going to actually push him away from the therapeutic net so that he goes and takes illicit drugs, he indulges in some other behavior. What will be the consequence? He'll either relapse, he'll either overdose, he will indulge in taking some other substances to take relief. He might indulge in some other behaviors, so-called addictive behaviors. Again, so what are we doing? We are consciously actually pushing away some of our patients, not all, some of our patients towards addiction because of our own belief set. Now understand, there you have to have checks and balances. All of them may not require higher doses. Yes, you have to evaluate whether a patient actually needs higher doses or not. Does he really have craving, or is he just trying to divert medication? Because of the nature of these substances, the diversion issue is real and practical, and one must be aware of it and take cognizant of that particular issue. But understand that most patients will not do well on lower doses. So most patients will require 8 to 12 milligrams of effective buprenorphine maintenance treatment, and most patients will be able to be maintained around 8 to 16 milligrams per day. So this is Western data. It is possible that some of our patients, Indian patients, might require lower doses, but that is something that is to be clinically determined. So target dose is about 8 to 16 milligrams per day, once in a day. Range is 4 to 24 milligrams per day. The maximum dose is 24, but some studies have gone up to 32 milligrams per day. But as I said, because of the ceiling effect, it's quite safe. So what I need to, we did not, 25 years ago approximately, we did not have enough technology, I would say, to study what happens with receptors or how many receptors are occupied. And fortunately, we have imaging now, imaging techniques now. So buprenorphine binds to opioid receptors, producing prompt blockade, as we have said, as I've said earlier. Now, PET scanning indicates that buprenorphine 2 mg produces only 41% inhibition of carfentanil binding. Carfentanil is an analog of fentanyl, which we all know is a raging epidemic in the US. 16 milligrams produces 80% inhibition, and 32 milligrams produces 84% inhibition. What does this mean? So if you give 2% to 2 mg to a patient, it only produces 41% inhibition of carfentanil binding. If you increase it to 16 milligrams, it produces 80%. But if you increase to 32, the increase is not higher. As I said earlier, as you increase the dose, the receptor occupancy plateaus. So between 16 and 32 milligrams, it is not very high. It's only 80 to 84%. But between 2 and 16, it's very high. So understand that a good dosage of 8 to 16 milligrams would be enough to produce about 80 to 85% of inhibition. Withdrawal suppression appears to require less than 50% of mu opioid receptor availability. And thus, if you're targeting only opioid withdrawal suppression, you require lower doses. But if you're targeting craving and reinforcing effects, then you need much higher doses of up to 8 to 16 milligrams per day. So please understand that with every opioid, there are three things which are very important. One is the analgesic effect. The analgesic effect comes in very, very low doses. It could be 0.2, 0.4, 0.8, 1 milligram. That is good enough sometimes to achieve a good degree of analgesia, but that will not suppress withdrawal in opioid dependent patients. For withdrawal suppression, you might require 2, 4, 6 milligrams per day, but that will not suppress craving. If you want to really suppress craving, you need to give higher doses. So please bear in mind these three different requirements of doses in different kinds of patients and what you are actually targeting when you're treating a particular patient. So fixed arbitrary limits on buprenorphine dosages in clinical care or limits on dispensing are completely unwarranted. It should be left to the judicious decision of the treating physician. So there are many, many studies, and this is just one of the studies coming out from Mohan, that we use too little dose and too early discontinuation. And they've shown the adverse effects of what happens when you use less doses or use only short-term treatment on adherence and treatment retention in patients of opioid overdose. So this is a homegrown study which is there, and anyone can go through it if they want to. These are two documents I would urge all our participants to read. These are documents. I'm the primary author of both these documents, and we have had a lot of support from lots of other people, especially Dr. Atul Ambekar from AIMS and many other prominent addiction specialists in the country. They are freely available. Please go through them. And you can find regulatory issues, procedural issues with regard to treatment with buprenorphine in both these documents. So I would urge you to please take out time and read them. So in summary, just last 3-4 slides. Opioids are powerful drugs that usurp and overpower the reward function of endogenous opioids. They induce dramatic changes in tolerance and withdrawal via molecular and neurocircuitry neuroadaptations, which is seen earlier within the reward system. I have not dealt with these in detail because that was not the mandate for today's webinar. They engage the brain systems for stress and pain, somatic and emotional, while producing hyperalgesia and hyperkataphia. Remember these terms. Patients of opioid dependence have lower pain threshold and have a persistent, pervasive, negative emotional state. That is hyperalgesia and hyperkataphia, respectively. And this, despite whatever happens, whatever we may want, these things persist over months to years. The drive pronounced drug-seeking behavior via processes of negative reinforcement. So these two processes of hyperalgesia and hyperkataphia tends to drive a person towards seeking a particular illicit substance. Opioids reprogram the epigenetic and transcriptional landscape of the brain, and we know everything is now with a combination of genetic and epigenetic interactions. OST reduces craving, withdrawal, reduces tolerance. The effects are immediate at the receptor level, but longer-term changes are seen in neuroadaptation and synaptic areas. Changes occur over a long period of time. So this is true for most drugs, and this is true for OST2, that at the receptor level, which I've described earlier, things are quite clear, and why the unique properties of buprenorphine seem to work. And but longer-term changes do occur in neuroadaptation and neurosynaptic changes, which help a person to actually become absent, retain in treatment and not choose illicit drugs. OST is safe, effective, scientific, and robust. But this debate is actually has been over a long time back about its safety, efficacy, effectiveness, whether there's a scientific basis to it, and the robustness of the evidence. The debate these days is only about ethical issues and stigma related to the treatment. It is not about the scientific basis of treatment. So the last slide. In medicine, we aspire to cure disease. This is what we've been taught, and we must cure a disease. but a contemporary understanding of addiction points to this fallacy and danger of this perspective. This is what I want to highlight again, what our chairpersons have said earlier. But what are we doing? What are we treating? When do we get this person off a drug? Only if he comes off a particular drug that he's okay or he's recovered. So in medicine, we aspire to cure disease. This is our training. This is what has been embedded into us. So our patients frequently ask, this medication worked for me and now I'm better. Can I stop? The reality is that the patients in remission from opioids may experience strong cravings for years after their use, and we tend to forget that. And with the loss of tolerance and availability of synthetic opioids or any other opioids, a single dose of usage of an opioid after a period of withdrawal can become lethal because it leads to hypersensitivity. Recognizing this nature of allostatic changes, clinicians may need to help patients shift their perspective into a chronic disease model, as for diabetes or as for other psychiatric illnesses or hypertension. So they have to recognize that there is a chronic disease model. So when a patient asks, this medication worked for me and now I'm better, can I stop? The answer should be, this medication is working for me. That's why I need to continue to stay on it. Thank you so much.
Thank you, sir, for your lucid and thought-provoking presentation. Dr. Prasanjit, over to you for
Yeah. Thank you, Dr. Ashwin Mohan, for such a nice presentation. And I fully agree with most of your points. And there are various aspects of opioid substitution therapy. I have one personal question before going to the audience to you is, although in the indications we know that someone has to be a IDU, intravenous drug user, someone has to be more than 18 years, and a minimum duration of at least 3 months of IV abuse. So my question is, to prevent non-injectors to injectors, can we use opioid substitution in those who only abuse through non-injectable mode?
Can you, sorry, can you repeat it, please?
To prevent conversion from non-injectors to injectors,
Yes.
can we or should we, in some selected cases, use buprenorphine to those who are non-injectors?
Yes, I think you're right. You see what happens in a life cycle of a person who's, say, abusing or dependent on heroin, they keep shifting from injectable to non-injectable use of heroin, depending on the amount of money, the kind of situation or context that they are in. So there is no prediction that a person who's not injecting heroin will actually not go on to inject heroin. This is very, very frequent. Eventually, what happens over a period of few months to a couple of years, they start having they don't have enough money to get their fix, and so they start taking lesser doses and they start injecting because they feel that they'll get a better high using an injectable drug. So and it is accompanied with its own consequences. So now what is important to understand, if you start treatment much earlier, you might actually prevent them from going into injectable drug use. So I will disclosure here, I am a total liberal in terms of usage of buprenorphine, and I will definitely advocate the use of buprenorphine in such patients.
Thank you. Thank you very much. And regarding the doses, what in my experience as the nodal officer in the OST, usually we go up to 5 tablets in the beginning when we induct a person. Within a month or 1.5 months, most of the patients maintain well with 3 tablets, that is 6 milligrams. And yes, one should not be very rigid about the dose. One has to actually take good care of the withdrawal symptom and craving.
Exactly.
With these few words, yeah, thank you. I would like to hand over to our moderator for handling all the questions. I think there are a good amount of questions in the chat box. Over to the moderator.
Thank you so much, sir. First of all, I would like to thank Ashwin sir. Yes, I would like to thank Dr. Ashwin sir for such a lucid presentation Although the topic is very vast, but I think I can speak on behalf of the entire audience that it was a good update on the neurobiology of how opioid works and how OST can be handled, as well as the practical clinical aspects of the dosages that we need to use when dealing with patients with opioid dependence. There are a few questions, a lot of questions actually from the audience that have come up. And once we are able to tackle with them, I had a few questions of my own. The first one I will just say before this. So you spoke about the incentive salience as well as the emotional dysregulation and the hyperkatifia. Now, is that exclusive to opioids, or will we be seeing that with other substance use as well? Especially the incentive salience part can be there for alcohol dependence or other drug abuse. And then how does that justify OST only for opioid and not similar treatments for other substances?
Yeah, so yes, you're right. I mean, obviously, the brain is an organ with the same circuits, and most of the substances affect all these three areas, all these three circuits, in more or less similar ways. So maybe one more, one less, depending on this thing. But right now, we have not actually uh, uh, used treatment of one particular substance, say, for example, buprenorphine or methadone, and use it for treatment for other substance use. Although cannabinoids have been used for treatment of opioid, naltrexone has been used for both alcohol and for opioid treatment. So there are some examples of where we have used a particular substance for different kinds of addictive disorders. But obviously, there are a lot of ethical issues here. And that is probably what prevents us from actually trying out or even attempting to research usage of one particular substance, because these are controlled, regulated substances. To get any kind of ethical or regulatory approval itself is a huge task. So I will not dismiss your question. I will say it's a very interesting question and one that needs to be explored. If we ever get a chance, or if people who are researching in this area get a chance, they should do that. There is always an opportunity. I will give you again a simple example. I have done a couple of talks on psychedelics earlier. Yeah, am I audible?
Yes, sir.
I have done a couple of talks on psychedelics. Psychedelics are also considered to be illicit substances and are banned. And only recently, because of some entrepreneurs and certain researchers who have really done a lot of good work, psychedelics have been shown to be useful in all kinds of addictions: nicotine, alcohol, opioids. So how do we come to that conclusion? There was an opportunity to actually do research in these areas. Only then we have come to this particular kind of use of these psychedelics in these addictive disorders. So there is a huge opportunity here, which we are yet to explore.
Okay, so thank you so much for that. And moving on to the questions that we have in audience, a lot of people wanted to know what are the long-term side effects of opioid substitution therapy, and how long, like you've already mentioned, it's better if we can continue for a year or longer. But then what are the side effects that we're looking at when we look at such long duration of treatment?
So the first coming to opioid agonist treatment, the long-term side, lots of other psychotropics, the long-term side effects minimal. If we are able to maintain the patient on a particular dose and he complies with that particular dose, there are hardly any side effects. The things like constipation, headache, and all of them are all transitory. Okay. And patients are actually functional and doing really, really well. So they do not affect any other body systems per se as such. So no real long-term effects. I have actually seen patients who have been there on on OST for 10 to 15 years and doing really well, unless they have some other kind of a comorbidity. That's a different issue. But otherwise, they're doing 15 years. I have some patients who've seen in 20 years. So 20 years is not a short period of time.
No, definitely not, sir. So in these cases, do we ever label these as abstinent, or we only label them abstinent when the OST is also completely off? And in that case, what is the tapering regimen that we need to follow?
We need to set our own targets, what we want to achieve. If we feel that he's away from any illicit opioid and that is good enough for us, then that's fine. So our targets need to be, it's a very collaborative decision with the patient of what he really wants. We will encourage him to reduce the dose and we'll see when he can do it, but we will never force him to reduce the dose. He will do it at his own pace. And mind you, I'll tell you this very honestly, most patients tend to reduce the dose on their own. They are much happier in reducing the doses on their own. At some point, some people will get off the dose, some people don't, but most of them are very, very happy getting off. Now I'm reducing the dose and people who've been put on 6 to 8 or 10 milligrams per day, after about 6 months, they come back and say, I'm just taking 2 milligrams per day. So they actually attempt to reduce the dose. It's not that they're seeking to keep themselves on 5 to 8 or 10, 6 to 8 or 10 milligrams per day.
Okay. And so what about OST when it comes to polysubstance dependence? We get, usually in clinical settings, we get patients who are abusing a lot of different substances. Where does the role of OST come there? Because like you said, research is very shady, or there are no research available on the use of buprenorphine and other substances. So how do we treat that?
So in a case of polysubstance dependence, what is important to understand is that whether is he actually dependent on them or not. Are they recreational uses, or is an adjuvant use because he uses one substance and uses the other one to increase his high or not? So first we must find out if all the substances that he is using, is he dependent on them? 1. 2, which requires intervention first. If he is using injectable heroin, do we treat that first? Whereas compared to maybe using 2 tablets of alprazolam or something like that, which we may postpone later, or he's using low cannabis, which may not actually interfere with his functioning, and he does not really want to reduce cannabis at all because he feels that it is actually calming him down or making him work better or something like that. So again, it's a collaborative decision about what the patient really wants, which thing does he want to stop. If he really wants to take treatment for opioid dependence, then definitely my suggestion would always be use OST, irrespective of polysubstance use. Because in any case, if he's going to use heroin or any kind of an opioid like that, there are much greater chances of an overdose occurring, while it is much less when you put him on treatment.
May I request the audience to please mute themselves so that we can hear each other better? Thank you so much. So coming to the same situation, are there any drug-drug interactions when we are treating other comorbidities when it comes to mental health issues in with OST? Or like if you said once we delineate that it's the opioid that we need to target first, and the patient continues using, let's say, alcohol or other medications, are there any drug-drug interactions? Sorry. So are there any drug-drug interactions when it comes to usage of buprenorphine because, with other medications for comorbid mental health issues, as well as for other drugs of abuse that the patient might be continuing?
Generally, alcohol and opioid agonist treatment is supposed to be a complete no-no. Practically, I've seen many people using opioid agonists in the morning and having their 2 large pegs or 3 pegs in the evening, or younger patients who use opioid agonist therapy and continue to use cannabis. In fact, some actually use heavy cannabis. Some use benzodiazepines for sleep, controlling their anxiety. So this is very, very common in practical terms. But if you ask me about whether we should tell them to stop other substances, we have to give them a categorical no and say that you must stop, because we never know when this kind of interaction might occur, or when they might have an overdose or something like that. So we have to be careful, but practically they keep using it.
No, so not just the substance, but also the other medications, other psychotropic medications they might be on for their comorbid, let's say, depressive symptoms, or
so a large number of patients would require other psychotropic substances like antidepressants or anti-anxiety agents. And technically speaking, because of the depressant action, we must be very careful in using other substances which can cause CNS depression, but otherwise no other real interaction.
No real interaction. Okay. So
One question I would like to ask.
Yes, ma'am, please.
Sir, we have seen in our practice that we have put a patient on OST, we have stabilized them, and suddenly they want to go to back to their native place. I'm from Mumbai. So many of the patients want to go back to their native place, and when they return after 2-3 months, they deny the permission for OST. They are not willing to continue OST.
Yeah.
And of course, they have consumed something over there, so they will need OST, I know, or
Yeah.
but patient is denying the consent for OST. In that case, of course, we admit them and all, but what would be your stand? They don't want to restart, because the problem is, I don't want to come every day. That everyday treatment is a thing. You do something and you can give me, if you can give me a weekly medicine, I am okay with it. Or if you can call me once in 3-4 days, I'm okay with it. So in such scenarios, are you considering BPN plus N for such patients?
So yeah, I mean, in general terms, take-home doses usually consists of BPN, buprenorphine, and naloxone combination. So, and what you're talking about is more of a logistical issue. I mean, it is most of our patients belong to the middle class, lower middle class, and the upper middle class and upper class tend to arrange their own medications easily. So really, I mean, that's a fact. So the point is that it's very difficult for them to come every day, leave their work, and many of them are daily wage workers, and they cannot stand in a line for so many hours together. So this is a logistical issue which needs to be addressed, and take-home doses have been shown to be very, very safe. And how much can you divert? And you give him 3 tablets or 8 tablets or 6 tablets for 3 days or 4 days. How much can he divert? He really cannot divert. Even if he takes an overdose, nothing is going to happen to him. That's the fact. So we must not be. We must be very mindful of this before we restrict take-home doses to certain patients who may be genuine. You might not do it in the first 2 visits or first 5 visits, but if he's coming for 1 or 2 months and you're fairly confident that this guy is going to be regular in his treatment and will continue, then why not? See, you see, there is something called iatrogenic dependence, and this is what I call iatrogenic dependence. Because we restrict a patient and restrict amount of medication or duration of medication and dose of medication to a patient, we're actually pushing him towards relapse.
Yes.
The brain doesn't understand it. But the brain does not understand daily take-home dose. The brain does not understand all of that. As I said earlier, it's looking for relief. You can't do it, it'll seek somewhere else. It'll take someone else's medication, वो divert कर लेगा, किसी और का पैसा लेके वो कर देगा, but he will do it. Because we are not in consonance with his treatment plan.
Bodily needs, right.
So,
Thank you
ma'am,
for addressing this most important issue. Abha, over to you.
Thank you, ma'am. So are there any strict regulations on the maximum number of drug doses or maximum days for which we can give take-home doses? So because
no, every center has its own policy. There is in terms of legal. If you talk about legal requirements, no, there is nothing like that. There is no bar on the duration of the dose of treatment. And this is very clear. It's on the autonomy of the doctor to decide what he wants to do, what he does not want to do. That is one aspect of it. Generally speaking, what people follow is that initially for the first few days, call him daily. Then after that, maybe twice a week, then once a week, and maybe then once in 2 weeks or so. If he's going out of station and he's got reasonable proof and you have reasonable faith that person is going out or there's some exigency or emergency coming, then fine, you may give him for a 1 month treatment too. And believe me, most people do well. They will come back after 1 month only. They will not come back earlier, except for a few percentage who might do so, but they will come back after 1 month and take their dose for the next 1 month. So the implicit issue here is, do we trust our patients?
Yes.
Most doctors will not. And that is a fact. They feel that every person of drug addiction who has come for treatment is actually wanting to abuse drugs further. So there is this implicit distrust for these kind of patients, not just opioid dependent, for all of them. And this fact that तुम छोड़ना नहीं चाहते हो, तुम कभी नहीं छोड़ोगे, फिर भी तुम ये बदलाव नहीं कर रहे हो, and stuff like that, without understanding that we are actually playing a part in it.
Right. So in this context, the recently approved FDA law injections for buprenorphine weekly and monthly, whenever they do come to India, might be helpful to address that issue.
To an extent, yes, but they're very, 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 very expensive.
Yeah, of course. So right now, that's a distant dream, I'm sure, for us, but something in the pipeline. There are also questions about the usage of naltrexone versus opioid substitution therapy. And in case we do decide to choose naltrexone, what should be the duration and the maximum dosage of using naltrexone?
Okay. So naltrexone, of course, is an opioid antagonist, so it blocks the receptors, and because of that, it does not address some of these issues which drive addiction. So some of these things are partial stimulation, which can offset seeking further drugs. So all these things are not taken care of. Although the naltrexone by itself is useful to so that because it prevents any further opioids from having effect when a person is on naltrexone. Now, the issue is of compliance. Most patients do not take naltrexone even for longer periods of time. So if it's supervised with good families and psychosocial support and patient is willing and voluntarily on taking naltrexone, then good. Please put him on naltrexone. Otherwise, most patients will not do it. That is one. So the other problem with naltrexone is that if a person leaves naltrexone and a person is abstinent for a longer period of time, what happens is that he's much more prone to an overdose death because his system in the brain is already hypersensitive to any kind of use of opioid. So even a lower dose of opioid use can lead to an overdose and death. And this we've seen very, very commonly. That is the second problem, apart from the issue of compliance. And third issue is that it does not address craving to an adequate level. So craving will still be present in the patient who's on naltrexone. That is the third problem, which is there. As far as doses go, although the recommended dose is 50 milligrams per day, I have commonly used 100 milligrams per day in many of my patients. The only limiting factor to an extent would be cost because it's an expensive molecule, but I use 100 milligrams. 50 I feel is not enough in many of my patients. I use 100 milligrams, maybe because of the belt that I'm dealing with. Yeah.
So another logistical question is, can we hand over OST treatment to the caregiver or only directly to the patient? So,
okay, usually the patients are the ones who take treatment and administer the drugs themselves. Many of them do not like supervision. So if it's done with the consent of the patient and all that, you see, they are adults. So they can take decisions on their own. Whether they take the right or the wrong decision, they can take decisions on their own. So expecting them to, the family members to actually supervise their treatment daily is really very difficult. Second, very important point. Many patients do not reveal to family members that they're taking treatment. See, they feel ashamed or embarrassed, or they feel there's some adversity might happen, or ghar se nikal denge and stuff like that. So many patients don't reveal that to family members. So you have no choice but to give it to the patient themselves. So only family members come to know of it much later that a person has taken treatment. So we don't refuse a patient. If they bring the family members, good. If they don't, too bad.
so in cases of like daily wage patients like Sarika ma'am who's eliciting to, in case they are unable to come and they are enlisted with us, and if their caregiver come to pick up their doses, do we give them, or we legally allowed to do that, not allowed to do that? So
yeah, so you see proxy dispensing is definitely discouraged. Again, not a hard fast rule, but if you feel that a patient has got a surgery done, can't move, and therefore the caregiver wants to give patients, then if you're fairly sure about these kind of cases, then probably you could give with a caveat or a note in the prescription that this is what is the case of or some other kind of thing that patient, other issues that may be there with the patient. So then in that case, probably yes. But in generally, proxy dispensing is generally discouraged, strongly discouraged in fact. Legally, there is nothing for us to prevent or permit us to do this or not. But then if it goes in the wrong hands, then it becomes a problem.
So one question, what is your experience of naltrexone in polysubstance use, as in opioid, high doses of cannabis, alcohol, everything, as in all stimulants, you just name it and they're taking it, kind of a situation?
So generally what happens is that my naltrexone would be my go-to drug in such kind of patients. And there are many reasons for it. Firstly, it can take care of multiple dependencies, like for example, alcohol and opioids, 1. 2, it can actually attenuate the reward processes for other substances. The person that they experience the reward when they take certain other substances, although it may not be recommended for those substances, but that reward feeling that they get, that reduces. So that is the second advantage of that. The third advantage is that many people who have polysubstance users have many other traits like ADHD, conduct disorder, antisocial traits, some externalizing behavior and all that. So naltrexone tends to help to control impulsivity too. So that is the third advantage of naltrexone, using naltrexone in this kind of a population, that we can take out of multiple targets using one particular medication. So in these cases, I would definitely feel that naltrexone is more advantageous as compared to going for OST.
We have an audio question that Dr. Paramveer sir would like to ask. Sir, if you could unmute yourself.
Hello, sir. Good evening.
Yeah, good evening.
Sir, thank you for the wonderful lecture. Just a small comment before I ask the question. What situation we are facing currently in mostly opioid infested is something like if you have a magical or a very good cure for lung cancer and you're not allowed to use that.
That's true.
That's how people know how much it is good for opioids.
Correct.
So my question is just twofold. So the first is that once the patient is maintained on a particular drug, on a dose, let's say 8 in your experience, when is the first time you would make an attempt to reduce the dose? Like usually I tell them that after 3 to 4 months, maybe by a 1 milligram reduction can be tried carefully and we see how you respond. Do you usually go by this, or is it longer or less longer?
Okay.
So the second question is that, sir, you had mentioned that state of dysphoria, the Kafka. Sir, that is seen in a lot of heroin patients, but sir, in my limited experience with the patients using so-called soft opioids, Beam and Payhas, so that is not seen so much. We see patients taking them for like 30, 40 years. And the only reason they come for OST is because the Afim or Poppy husk is not easily available. So your comments on that.
Correct. Okay.
Thanks.
So with regard to the dosage, if you look at the craving data or how craving tends to reduce, let's focus on that. The maximum craving occurs in the first 3 months. After that, the craving tends to reduce over the next 3 months. So 6 months, the craving tends to reduce. And after a period of 1 year, the craving tends to reduce substantially. So your guideline of reducing the doses after about 3 months or so is quite valid. Now, it also depends on whether you're targeting withdrawal symptoms initially, and therefore he is stable on it, and you may attempt to reduce it with the consent of the patient. If the patient is agreeing, fine. If the patient is not agreeing, don't do anything much. After the 3rd or 4th month, as you have said, you can reduce, whether by 1 or 2 milligrams is not yardstick or something which we can recommend it. It all depends on how well the patient is doing. So it could be anything, 1-2 milligrams or so every month, because you see it's a slow acting medication. It takes time to see the effects of after reduction, or whether the craving is resurfacing or not. So we can't hurry this kind of a reduction, and in these kind of patients we have to wait. There is no other choice but wait and be patient and see whether the patient is actually displaying behaviors, whether he's going to his the same places where he's used to take the drug, or subjectively experiences craving and expresses it to the treating doctor. So you have to monitor all these things and then take a call on whether you have to reduce it further or not. As I said, 6 or 8 or 10 milligrams doesn't matter. What you're looking at is stability of that patient. So the dose really is not important. Whether it's 50 milligrams sertraline, 100 milligrams sertraline, 200 milligrams sertraline, hardly matters. I mean, why are we so concerned about the dose? Here, with regard to treatment of addictive disorders, well, we are not so concerned about the dose in, say, other psychiatric disorders such as anxiety, depression, etc. So why are we so concerned about it? We should not be. And that is what I wanted to try and bring out in this presentation, is that we should not be so concerned about it.
Yes, sir. Thank you
and
so
the second
much.
question, sorry, Paramveer, your second question was about
the soft opioids.
Yeah, you are actually correct. Yes, you are actually correct. Heroin and some other kind of opioids are very, very potent dysregulators of this system, the reward system, as compared to the so-called soft opioids such as poppy husk and opium. And you have seen, and I have seen, and I'll agree with you, and I for the benefit of others, We have seen people who have taken copiers for 40 years, 50 years, 60 years with no problem at all. And opium, small doses of opium, not even, I would say, larger doses, but 1 or 2 grams or 3 grams of opium for decades together, enjoying their life without having any kind of dysfunction, dysphoria, any distress or anything like that. And the day they shift to heroin, everything starts. All these problems tend to start.
So there's another question about OST in patients using injectable heroin along with methamphetamines. So what is the role of OST? About using OST in patients who use injectable heroin along with methamphetamines. Does OST have a role there when there is a codependence with methamphetamines?
Particularly not with methamphetamine.
Along with injectable heroin.
Yeah. I mean, if you want to treat the heroin dependence, definitely OST has a role, but not particularly for methamphetamine dependence. But please understand another thing. Methamphetamine is a stimulant, and you must ask the patient why he is taking methamphetamine. Methamphetamine itself can actually lead to much more relaxation, calmness, and stuff like that. Whether you can actually use something else to provide him that kind of relief is something you'll have to ask, because many of these psychedelics have got depression or anxiety relieving properties. Maybe he is using that to cope with that kind of symptom. So please find out whether he's that. Second, of course, is whether he's got ADHD or not. And you have not put him on treatment for ADHD and he's continuing methamphetamine, because again, it reduces aggression and increases his focus and concentration. So please explore whether he's got ADHD or not, and find out whether you need to start treatment on that. And that itself may be enough for him to leave methamphetamine.
So there are a few questions on, are there any studies on Indian studies for data on diversion? And if in case we get to know that the drug is being used as a diversion, do we need to inform the police? How do we go about it? What is our role in all the?
You see, ideally we have to there is data on diversion in India. There is some data, although not too much. I'm forgetting the studies. I must have read some time back. But what is our role? Our role is not to inform the police. Our role is to tell the patient that we know this is happening and he'll be terminated from treatment and leave it at that.
Okay.
So if you overstep our jurisdiction, we can actually tell every patient that तुम आओगे, तुम्हारे पास अगर drug होगा तो हम पुलिस को inform कर देंगे. So where do we stop?
Right.
So we must actually be very cognizant of what our role is.
Okay, sir. Thank you very much, sir. I hope I have been able to cover all the questions that were there from the audience. There is also a question of, are there any courses or fellowships that we could do for better understanding of the addiction psychiatry and to set up OST clinics? And I'm sure, feel free to answer that also, sir. And thank you so much for these practical, clinically useful tips. And as a last comment, Dr. Talaha says, so lifelong OST can be given without any hustle legally and medically. That's what his take home has been from this talk today.
Okay. Yes, of course. Yes, of course. It can be given. See, just a couple of things and just one or two odd questions before we end. Yes, it can be given lifelong in some patients because they require it. 1. 2, you will always make an attempt to reduce it at some point of time, discussing with the patient. The patient is always engaged and you don't force the issue. So it can happen after 3 months. I have seen umpteen number of people who have left OST in 6 months' time, completely. And they're doing very well. And they've never come and touched anything. They come back to me after 1 year, 1.5, 2 years and say कि मैं तो इसको साथ में लाया हूँ, मैं तो 1.5 साल पहले छोड़ दिया था दवाई आपकी और मैं बिल्कुल ठीक चल रहा हूँ. So there are many examples of that. So don't assume that everybody will require it for as a lifelong treatment or a very, very long treatment. There are many people who stop and taper off on their own, as I said. One. Second, there's this question that I have seen patients taking OST and selling them outside to their friends, taking some by themselves. Any comments on this? So obviously it is not a favorable situation, but please understand, whom are they giving it to? They are giving it to fellow addicts. So what they're actually doing is they're doing a service to them, because I should not be saying this, and I'm not encouraging any of this kind of behavior, and I'm against this, but they're giving it to patients who may not ordinarily be able to access this kind of treatment, or this treatment may not be available to them or they can't afford it, or they don't have the time to come to the clinic. They don't want to reveal their identity. So there are many issues. So they're actually giving to other patients of opioid dependence. So they're actually doing a service by reducing their chances of overdose, mortality, or any other kind of consequences. So don't encourage it, but you know why it is happening. And this comes with the job. And this is something which one has to accept.
Thank you so much, sir. I think everybody has been left with a positive note on the usage of OST and will be a little less hesitant when having to start it. Thank you so much. On that note, I would like to hand it over back to the IABP team.
Thank you so much, and thank you for the opportunity. I hope I've been able to do some justice to the fact about why this is a treatment and this is not substitution. That is the message. I hope some people have, there'll still be some doubters and fence sitters, but that's always true for every treatment. But I hope majority of them have understood what.
And if I may add, your humanitarian approach and inclusiveness is really encouraging. And I mean, we have been doing it, but we'll do it more robustly, looking at the example and the way you have forwarded it to us. Thank you so much.
Thank you, Dr. Mohan, for such a nice handling of the questions. And people are actually asking for your email ID. If you allow, we can share it.
Pardon?
Some of the audience, they are asking for your email ID.
Oh, okay. No problem at all.
Thank you. Thank you. Thanks, Dr. Ava, also for nicely moderating the session. Over to Dr. Abdul Majid, our Joint Secretary of IABP, for vote of thanks. Dr.
Thank
Majid,
you, Dr.
please.
Prasanjit. Yeah. Dr. Prasanjit, thank you so much. Connecting biological psychiatry has been connecting people from all over the place across India, north, south, east, west, and central zone. So it's always good going. And Dr. Ashwin is nothing new once it's about addiction, and he speaks. His today's lecture speaks volumes about his experience and knowledge that he has in the field. Dr. Ashwin, thank you very much for a very, very lucid talk. And
thank you, sir.
Dr. Prasanjit, thank you very much. Dr. Abba and Dr. Sarika, I think you have done a wonderful job by making this session very, very interactive. Obviously, the big thanks to our General Secretary, Dr. Uksheda Saida, who is the anchor of this Friday series. Dr. Aleem Siddiqui, our editor. He is very important part of the CME series. Dr. Sunil Mittal, our president, Dr. UC Garg. Everyone from the IABP team, be it Dr. Anukant Mittal, Dr. Pramod Kumar, Dr. G. Prasad Rao, I think all of them have been contributing so much to make this series very, very successful. May I remind our all viewers who are here that we have IABP midterm CME in Srinagar on 22nd and 23rd of July. And along with the Banai International CME. So all of you are invited for the same. And before I sign off, I would like again thank the speakers, chairpersons, moderators, IABP team, and the delegates for being present for more than 1.5 hours since 8 p.m. Thank you all, and we'll see you again in next Friday CME series of IABP very soon. Good night. Take care.
Thank you. Thank you.
Thank you so much. Thank you.
Bye-bye.